Okay, so this is a talk of the selective reduction where we supposed to have it, I think, before lunch. I think it's gonna connect. Do you prefer the light on or the light a little bit off? Are you sure you don't fall asleep? Do you want me to do it from here? Yeah? Okay, perfect. So selective reduction. So what are the indications? Where are the potential scenarios where you would actually consider offering selective reduction or selective termination? Well, I mean, obviously the most straightforward if you have discordant anomaly or discordant aneuploidy, but also if you have advanced TTTS. So like stage 4, for example, when you have hydropic in one baby, especially if it's early onset, you might actually consider doing offering selective reduction in view of the poorer prognosis. Or if you have severe early onset selective vasoconstriction, for example. Or if you have twin reverse arterial perfusion. Or if you have TAPS, particularly again if there is stage 4, for example, or there is hydrops. But even in uncomplicated higher order multiple pregnancy, triplets or higher, we should offer routinely the option of selective reduction, ideally in the first trimester. I showed you a slide in the morning, which is from the ISWA guideline, is that what should we do in dichorionic twin pregnancy? Straightforward, transabdominal, ultrasound guided, use a 20 or 22 gauge needle, the same needle that you use for the amniocentesis, and you inject either KCL, most likely, or some people use lignocaine, and you either do it intracardiac, the most common technique, or potentially you could also do it intrafunicular inside the umbilical cord, and as I said, preferably in the first trimester. And we mentioned earlier, if a diagnosis is made in the second trimester because it's a particular abnormality or the indication arose in the second trimester, in this case, you have to follow the law where you practice. And if you work here, for example, in the UK, where the option of selective termination or termination late in pregnancy in the third trimester is valid for a certain indication, that will be the preferred option. We also discussed in monochorionic twins, it's more complicated. We can't use KCL because of the circulation, and therefore the only options so far are either cord occlusion or intrafetal coagulation, either using the laser or using radiofrequency ablation. So when you counsel this woman, so you've got a triplet pregnancy, and you saw her in the first trimester, you did your 12-week scan, detailed scan, and then you sit down with the parents to have a counseling. So what should you do? What should you tell them? Well, you need to be really clear about the facts. Reduction of triplet pregnancy does not improve the chance of survival. The survival rate is the same, similar, whether you continue as triplet or whether actually you do reduction. What you're doing is that you're reducing the chance of extreme preterm labor, and therefore you're reducing the chance of cerebral palsy or disability secondary to extreme prematurity. And therefore the options are one of three. Either you continue the whole pregnancy, they still have more than 90% chance of survival and probably good outcome, or actually terminate the whole pregnancy, and certainly that can be sometimes an option if this was unplanned, this is a forced pregnancy, she's got already healthy children, or actually do embryo reduction, and the options are either from 3 to 2 or from 3 to 1. When should you do it? Well, ideally we should do it at 12 weeks, so in the first trimester, much better than in the second trimester, because the risk of miscarriage and the risk of preterm delivery is much less if you do it in the first trimester compared to the second trimester. So this is from, these numbers are published. I personally find them useful because you can put them in front of you, so they're helpful when you counsel them. So this is the risk of miscarriage and risk of preterm birth before 34 weeks according to the type of triplet pregnancy, whether trichorionic triamniotic or dichorionic triamniotic, and according to whether you do expectant management, so continue as 3, or reduce from 3 to 2, or reduce from 3 to 1. And what you really see clearly is that the more babies you reduce, the higher the risk of miscarriage, but also you reduce the risk of preterm labor. And you see the same pattern in dichorionic triamniotic triplet, but the numbers tend to be higher. So the risk of miscarriage or the risk of preterm birth tend to be higher in dichorionic triamniotic compared to trichorionic triamniotic triplet, which makes sense. Because obviously there is also risk of TTS or the monochorionic pair. But sometimes you come across women who say, but doctor, I don't really want to reduce. If she have dichorionic triplet, so dichorionic triamniotic, I don't really want to have a singleton. And you say, okay, well, if you reduce maybe the monochorionic pair, because you have singleton, so you avoid all the monochorionicity-related complication. And also, she doesn't really want to have monochorionic twin and reduce the singleton because you still have all the monochorionicity-related complication. What she really would like, she likes the fact that they have twin, they're very cute, and I want dichorionic diamniotic twin. Is that an option? It's not, I don't think it's an option that's offered in all the centers, but certainly offered, for example, this is a King series, and you see it's quite small, it's only 22 cases of dichorionic triamniotic triplet where they did a laser ablation of one of the monochorionic pair. Yeah, so intrafetal interstitial laser ablation. And this is a simple technique. Use a CVS needle, then 18 gauge needle, and you use a laser fiber down the CVS needle. The problem with that actually if you do that, there's already 50% loss rate of the monochorionic twin. And if the women accept that, that's fine, but that's a risk. Some people sort of concern about the neurological outcome of the co-twin, but certainly according to this series, it doesn't seem to be a concern. Okay, so it's an option there, at least you know about it, but I don't think it's the preferred option. I think most people, when they counsel this woman, I think they will probably advocate maybe reducing the monochorionic pair, and therefore you continue with singleton pregnancy. So as I mentioned, ideally in the first trimester, which fetus to reduce? Well, it depends, really. So it depends on whether there is abnormality. So, for example, obviously you do detailed anomaly scan in the first trimester as much as you can see. And then if one baby has abnormality, probably this is a baby that you would ideally reduce. If the 3 of them are normal, traditionally, people try to go for the triplet that's furthest away from the cervix. Interestingly, we had a case which was a bit complicated, and in fact, the literature, there's not really strong evidence to say that reducing the lowest triplet actually increases the risk of miscarriage. But certainly conventionally, and most people would go for the triplet that's furthest away from the cervix. So I said that, which fetus reduce, you take into account a lot of things. You take into account whether there's abnormality, there is increased nuchal, if there's chorionicity or monochorionic pair, for example, and if there are 3 are normal, as I said, the one that's furthest away from the cervix, and also the one that's easiest technically, because you really want to make sure you avoid going through another sac, so another triplet sac, for example. So as I mentioned earlier, the counselling, the gestation age at the time of the selective termination was the main factor to determine the risk of preterm birth. The earlier, so ideally in the first trimester, the better, or the lower the risk. Okay, what about actually if you trichorionic triamniotic triplet, so IVF, trichorionic triamniotic triplet, what is the chance of spontaneous versus selective reduction? So of those that conceive through IVF and have a triplet before 12 weeks, what the chance that this pregnancy will continue as triplet? There's about 17% risk of spontaneous reduction. This 17% varies, this figure varies, according to what is your definition of spontaneous reduction. So for example, the IVF clinics will monitor, and actually they might say, fine, well, you've got 3 babies because there are 3 gestational sac, okay? And if the pregnancy continued as 2, that may be spontaneous reduction. Some other people would define and said, well, only when I have 3 fetal heartbeats, that means triplet, and that's what's the chance from that to end up by spontaneous reduction to twins, for example. The other question, what proportion of parents do they actually opt for selective reduction in this scenario? And what is published is about 57%, and certainly as my experience, probably 50-50. So when you counsel these parents, I would say probably 50% would say, thank you so much, I'm happy to continue with my triplets, especially IVF, they've been through a lot to get there, and 50% will actually opt for the option of selective reduction. And if you see the risk of preterm birth, less than 34 weeks, in a triplet that continue as triplet, it's about 60%. If triplets have spontaneous reduction to twin, it's about 30%. So you see it's less. And in a triplet that had a selective reduction to twin, it's about 20%. So you can see clearly that there is a reduction in the preterm birth, even in spontaneously reduced triplet. So as I mentioned earlier, in monochorionic twin, it's quite complicated because you can't use KCL. So you have to use a technique, invasive technique, either cord occlusion or intrafetal laser or radiofrequency ablation. So how do you counsel these parents? Well, regardless of the technique that you use, the survival almost 80%. So if you actually use 80%, you're quite right, whatever the technique. The techniques are either bipolar cord occlusion, and that's probably the commonest technique that we use for cord occlusion. Certainly there's also, you can use a laser, just a laser to coagulate the blood vessels in the cord, or cord ligation. Myself, I've never seen cord ligation. I don't think that's even practiced, for example, at least in Europe. When you do the cord occlusion, the sleeve, the operative sleeve is not small. It's about 3.8 millimeter. And therefore, it's really tricky to do that in the first trimester because the risk of miscarriage is quite high. So it's a big board, relatively big board. And as Lisbeth mentioned earlier, if you have a monochorionic monoamniotic twins, it's not enough just to do cord occlusion. You also need to transect the cord. Yeah. So what the complication of doing cord occlusion? Well, clearly the risk of demise of the other baby, the one that you want to leave. So the risk of demise, which is quoted about between 15 and 20%. But obviously, operative complications, so the risk of bleeding, and that could be either from the introduction site, but that's a small chance because it's usually ultrasound guided, and also from the placental surface. There's rupture of membrane, which is about 10 to 15%, risk of chorioamnionitis, and risk of neurological damage, which is up to 15%. And therefore, I think it's a common practice that people, if they will do cord occlusion, they will look at the brain, whether by ultrasound scan, if they're good, in neurosonography, or doing MRI later. So the problem with the cord occlusion, as I said, it's not a small port, and therefore it's tricky to do that in the first trimester. But also, if you have a short umbilical cord, it's technically difficult. And also, if you have anhydramnios, in this case, you might need to put amnio infusion, for example. The other option is to do intrafetal coagulation. And this is pictures from Leuven, from Elizabeth Louis, thank you, where actually the radiofrequency ablation is only 17 gauge needle, and therefore it's only 1.4 millimeter. Remember, the other one was about 3.8. So it's actually smaller than the port for the cord occlusion. And you can do it ultrasound guided. As I said, the loss rate is relatively similar, regardless of the technique that you use. So how does radiofrequency ablation work? Well, the principle is that it uses electricity to generate heat, and therefore that causes tissue coagulation. And this is a mechanism of coagulating the blood vessels. So alternating current, very high frequency, and you can see the tins here, so the needle, you open it inside, and have the tins, and therefore the electric current goes between the tins, and this is the one that generates the temperature or the heat, and if you have very high tissue temperature, that causes tissue coagulation and necrosis. I said this is a machine, this is how it works, this is a protocol, and I'm just going to spend a couple of minutes going through it because I suspect many of you are not necessarily doing it routinely or never seen it. And if you have a patient, you're counseling her, the patient might ask some questions, and it might be useful if you know it, even if you don't do it or you don't offer it. So it's usually done under local anesthetic. Most centers will give antibiotic cover for the procedure. As I said, that it's you use a needle, it's about 17 gauge, and under ultrasound guidance, you target the intrafetal portion of the umbilical cord, and you position the tip of the needle near the, as I said, that umbilical cord, and you can use that by doing color Doppler. Once you are in the right position, you open the tins, and then you apply your radiofrequency ablation cycle. So they go into cycles. A complete cycle is when you apply it until you get the temperature, average temperature of 110. That's across the 3 tens. And you do that for about 3 minutes. And then you have to have a cool down period of about a minute. And then you repeat the cycle again. Okay, suppose actually that the heating is not the same across all the tens. And therefore, in this case, you should stop, retract the tins back into the needle, reposition your needle, and once you are in the correct position, you deploy your tins, and then you have your cycle again. How many cycles do you need to do? It depends on the gestational age. Certainly, if you are at advanced gestation, you might need 2 or 3 cycles before you actually finish or complete it. How do you know that you finished it? You either have asystole in the twin, but sometimes you don't really necessarily have asystole. You just have cessation of the blood flow using the color Doppler. In this case, you can stop and then maybe just scan half an hour later to confirm asystole of this baby. Post-operatively, this procedure is usually done as an outpatient, so we don't really admit the patient, but ideally we should look for the MCA peak systolic velocity in the surviving twin the next day, because you want to make sure that there's no anemia in this fetus or in this twin. Often people would cover the procedure by, as I said, antibiotics before, but it's not unusual practice that people give indomethacin and progesterone for a few days post-operative or post-procedure. And obviously you talk to your referring physician and then consider offering either brain imaging or MRI at 28 to 30 weeks. Because remember, we said that there is a risk of neurological problem to the surviving twin. What about intrafetal laser or interstitial laser? It's really simple technique because most of you will do CVSs, so you're familiar with it. And you can see it here in this video. So it's ultrasound guided. As I said, we use the same needle as the CVS, so 18 gauge, 17 or 18 gauge needle. You use either the laser fiber, which is either 400 or 600 micron. So you pass it down the CVS needle, and you can use the laser either ND-YAG or diode laser, and then you target again the intrafetal portion of the umbilical vein, and then once you have the tip of the needle on the position, you advance the laser fiber 1 millimeter beyond the tip of the laser, and then you apply beyond the tip of the needle, and then you apply your laser. So it's really simple. So what are the risk and benefit of each technique? So the cord occlusion, as I mentioned, because of the larger diameter, is not something that you would offer in the first trimester, and therefore, and there's also risk of rupture of membrane or preterm birth. The benefit is that it's complete mechanical cord occlusion, you know for sure. While actually the laser and the radiofrequency ablation, I don't think is as controlled as cord occlusion. And as I mentioned, it's not enough to do cord occlusion. In monochorionic monoamniotic twins, you need to transect the cord as well. For the radiofrequency ablation or the interstitial laser, it's a slower occlusion. I think, personally, the risk of demise of the cord twin is higher, I think. And the benefit, as I said, it's a small diameter. It's something that's certainly in the interstitial laser, something can be done in the first trimester. But ultimately, the choice of the technique depends on your expertise and what equipments you have. So if you don't have access to radiofrequency ablation, well, that's not really an option for you. Okay, so in terms of counseling the woman, often women would ask the same question as what we discussed before: when is the risk is highest? From the studies suggested that the highest risk of demise of the remaining twin is usually in the first 2 weeks. So 80% of the cases of demise of the co-twin occur in the first 2 weeks compared to 20% afterwards. Does gestational age affect the survival rate? And certainly it depends, according to this meta-analysis that was published a few years back. It seems the risk is the survival is better if it's done after 18 weeks. But the survival, generally speaking, is about 80%, regardless of the technique. Okay, so selective reduction in triplet, the gestation age of delivery. Triplet, if the continuous triplet, the gestation age of delivery is about 33 weeks average. If they reduce to twin, it's about 36 weeks. And if you compare that to the primary twins, about 37 weeks. So the primary twins is a little bit higher, but not significantly higher. So by reducing triplet to twin, you're almost reducing the risk of preterm birth almost to the same risk as twin pregnancies. So again, here's the twin pregnancies, primary twins, and twins that are reduced to singleton. And certainly you do reduce the risk of spontaneous preterm birth and having a small baby. But I think from my experience, most twin pregnancies have good outcome. And therefore, I think the situation where you reduce from twin to singleton just to reduce the risk of preterm birth, I think is very small. Can we use KCL to do selective reduction after laser? Is that an option? And it's not something that most people would offer or would do, but certainly in the literature there has been some case reports of using potassium chloride for selective termination following laser for TTTS. So this is with only 3 cases at 18, 22, and 23 weeks, the different stages of Quintero. And according to this case series, all co-twins survived with no neurological morbidity. I'm not necessarily advocating this, but as I said, it has been reported in the literature. What about new techniques for selective reduction? And there's certainly sort of new technique, 2 new techniques, the microwave ablation and the HIFU, or the high intensity focused ultrasound. And I said the only case reports is not something that we advocate, or there is a strong evidence to back it up, but just for you to, at least for your knowledge. So the microwave ablation, it's a little bit similar to radiofrequency ablation. It creates heat, but without a circuit. And therefore, the advantage, it has less thermal spread and potentially less damage to the tissues from the heat. There's only case reports, 6 case reports in human, and they managed to successfully coagulate the intra-abdominal umbilical cord vessels of the acardiac mass, so in the trap, with cessation of the blood flow in all 6 cases. So, it's promising, but very early days. The other one, which is a high-intensity focused ultrasound, this mainly only in animal models. I'm not aware of any data in humans. Only case report in trap. And as I said, the localized tissue denaturation, but they have not completely managed to occlude the blood vessels completely. So really the take-home messages is that if you reduce or offer reduction for triplet, you need to know your facts accurately to be able to provide proper counseling to this woman. You do not improve the survival. What you're doing is that you're reducing the chance of extreme prematurity and therefore reducing the chance of disability secondary to prematurity. If you're going to do selective reduction, you really should not do it before 11 weeks, like all days, because you want to wait for the 12-week scan to do the nuchal translucency, look for any major abnormalities, because the worst thing is that you do the reduction and then the woman comes back and the baby have acronia or have major abnormality. Selective reduction in dichorionic triplet, as I said, most people would probably, their first choice would be to reduce the monochorionic twin. So you have singleton and the risk is less and you avoid all the monochorionicity related complication. If you're doing selective reduction, certainly you try to do it in the first trimester to reduce the risk of preterm delivery if you do it in the second trimester. And ultimately, the choice of the procedure will depend on your technical expertise and availability of your equipment. Thank you. Okay, any questions? Is there anything online? Yes? Should we have the lights on, please? Yeah. Andy.
Hi there. This is probably more a question for those of us who work in the UK, where we can perform termination without a gestational limit. I was wondering what people's thoughts were on approaches to use for late diagnoses, sort of outside of the window for cord occlusion, so sort of 28 plus weeks. I know there's no consensus, but I just thought it might be worth discussing.
In a monochorionic, I guess.
In a monochorionic, yes.
Yes, anybody would like to... So actually, hands up for people who work in a country where this is a legal option. A legal option. It's okay to offer it. Okay. So, okay, Kurt is here. So, Kurt, what do you think? I mean, what's your experience of offering a late after, like third trimester, selective termination in a monochorionic twin?
I wouldn't like to do it. It's very difficult to go for the cord then, to coagulate the cord. It can be a major procedure without success, and then you are trapped.
Yeah, you're right. Any
What about intraoperative reductions?
Yes, so Robbie raised something that I think personally, a lot of people outside the UK, I think they get shocked when they hear about this option, which is doing it on the table at the time of cesarean section using KCL. I'm not advocating this, and certainly don't do it if you work in a country where this is not a legal option. But Kurt wants to say something.
I'm surprised that this is a legal option in the UK, because in Germany, as soon as delivery starts, and if you start with a cesarean section, the fetus becomes a legal person, and you would get sued for manslaughter if you do that.
So it's covered under Clause E in the UK, and we do it before delivery, so it's all prepped up for us.
Yes, so I think what he's saying, Robbie, is that I think for us is that before the baby is born,
Yeah, so
while I think what Kurt is saying, correct me if I'm wrong, before actually they start the cesarean section.
Exactly. So we would do it. The patient would be all prepped up for a cesarean section. There would be a team ready to do the section, and then we would do a selective feticide using KCL if the lasers happen, or I've done it once without laser using intracardiac KCL, and then within 2 minutes, like a category 1 section, the team would do a cesarean section, and it is nerve-wracking.
Kurt, is that something you can do legally in Germany or no?
I wouldn't try it, because the media and the lawyers may kill you. I don't know. I am not aware of a case where it happened, so I wouldn't do it personally.
I mean, we've done, we did few cases, and as I said, look, this is something that's not, I'm sure 100% doctors don't like to do it. It's a horrible thing to do. And everybody's really unhappy about it, all the staff. But at the same time, as a parents, I think they are going through the toughest time. And therefore, I find my role is just to support them and of course, sort of follow the law and do things legally, but as you said, the way we do it, it does fulfill the legal obligation in the UK. But it's a horrible thing to do.
I mean, just going back to that, I mean, you have to remember that the connections between the mono twins are going to be quite substantial. I know one case where they did do that, and you're going to have a really competent surgeon get that baby out quite quickly. Because when they did the potassium in a surviving twin, it was about 7. So it's quite nerve-wracking. I suppose the other option is whether you pull the cord out, that section, tie that off, and wait for that baby to potentially die and then deliver.
I think this is technically more difficult than what we're doing.
Yeah.
Because I think everything is prepped. I mean, you're just about to open the uterus, really, and therefore I think that and often, I mean, we do it. You have 2 operators, the 2 fetal medicine doctors, and therefore one person is doing the ultrasound guided, and the other person is just ready to deliver. So I think the interval is is less than a minute often. So I think the risk is very small compared to what you're doing is actually because the delivery, I think, is less controlled because it depends. The baby will come and they start crying, and it's horrible, I think.
If there are some questions. questions on the last.
Yes, yeah. Okay, so from Elena, is there amount of time after which NIBT can be performed? Oh wait, I think we've done that. We've done that, I think. Rajivi, due to the low PAP-A in a monochorionic twin, is there any difference in the detection rate? And do you recommend NIBS in all monochorionic? NIBT, you mean, I guess. So that's, I guess, question to Katja. So I think, Katja, you mentioned the fact that the PAP-A, is she here? Okay, well, I mean, I'm happy to respond. So I think, but Katja, if you remember, Katja said that actually the beta-HCG, the difference between in monochorionic versus dichorionic twins is not big, it's not massive, while actually the PAP-A levels are different in monochorionic versus dichorionic twin. But actually what you do is that your algorithm adjusts for that. So the fact that you're telling your algorithm it's a monochorionic twin, that will be taken into account, and therefore ultimately, if you look at the data that I showed you in the morning, the detection rate for Down syndrome using the combined test is actually similar in monochorionic to dichorionic twins. So I don't think it's different. So the question, do you recommend NIBT in all monochorionic twins? I guess it depends where you work. I mean, for us in the UK, yes, I'd like to have NIBT in all monochorionic twins because it actually should behave like singletons. But at the same time, I think the ultrasound scan is more important because it gives you more information. It gives you it would diagnose acronia, it would diagnose if the baby have big nuchal translucency. So it depends, I guess, where you work. And if there's no financial limitation, because obviously there's financial consequences of doing NIBT. Okay, anything else? I think that's it.
One from Dr. Maypole. I'm not sure if you did that.
I think we've done that already, the cervix.